Good morning. Welcome back, everybody. So for this morning's session, the first speaker is Dr. Mohit Kasibhatla. He's a radiation oncologist that trained at Duke University. He was followed by serving on faculty at Dartmouth as well as Duke. He's now here at Roger Williams, and it's my honor to introduce him.
Thank you very much. I want to thank Dr. Katz and the organizers for the conference for inviting me, and thank all of you. I'm going to give a talk about radiation therapy, its biology, technology, and role in clinical practice. The talk is basically divided into three sections. We'll start with some basics and background in the biology of ionizing RT. What is it? How does it kill cancer cells? Then switch into the technology of treatment, how radiation is produced, and the alphabet soup of new technology such as IMRT, IGRT, and SBRT. And then we'll talk about some clinical roles in breast cancer, head and neck cancer, to illustrate the role of RT in trimodality and combined modality treatment. And then finish up with single modality treatment with SBRT for stage 1 lung cancer. So electromagnetic radiation is all around us, from radio waves to visible light to X-rays and gamma rays. It's characterized by wavelength and frequency. So radio waves have the longest wavelength, the shortest frequency. X-rays and gamma rays have the shortest wavelength and the highest frequency. Since energy is proportional to the frequency, X-rays and gamma rays have enough energy to actually break chemical bonds. So that's why they're called ionizing RT. And this is an example of an X-ray or gamma ray interacting with an atom. And if it possesses enough energy, it's able to ionize that atom, interacting with an outer shell electron, ejecting that electron, and that electron can then go on to produce subsequent ionization events. In biologic systems, the target of ionizing RT is DNA. The X-ray or gamma ray can either directly attack a DNA, but that's quite rare. More commonly, ionizing RT interacts with water in a process called hydrolysis to release a hydroxyl-free radical. And that free radical then makes its way to DNA to produce a DNA strand break. That process is much more likely in the presence of oxygen. Oxygen is able to fix that hydroxyl-free radical, increase its lifespan, and greatly increase the chance that it interacts with DNA and causes the DNA strand breaks. Ionizing radiation can produce multiple types of DNA damage, single strand breaks, DNA protein adducts, but the lethal form of DNA damage is a DNA double strand break. DNA damage is dealt with differently in normal cells versus cancer cells. So for normal cells, DNA damage is recognized effectively and repaired, and the cell is able to recover. Cancer cells have impaired mechanisms of DNA damage identification and repair. And so the DNA damage accumulates, and eventually the cell is either arrested in its growth pattern or it dies. That said, normal cells are affected by RT, and there's two types of side effects that these cells can experience. There's side effects during the treatment, and there are side effects that can occur late after the treatment. During the treatment, most of the side effects we see are in cells that are proliferating, such as mucosal cells, skin cells, and GI cells. So the patients will have mucosal, skin, and GI toxicity during the treatment. But these are reversible effects of treatment. The side effects that we really worry about are the late effects of treatment. And one of the late effects of treatment is a second cancer. These can develop 5 to 10 years after treatment. It's an effect that happens even with very low doses, so it's really impossible for us to prevent it. Thankfully, it's a rare event. The side effects that we really are concerned with are severe late side effects in soft tissue, bone, nerve, and vessels. And these effects are irreversible, and they can significantly affect the patient's life. So the best way to prevent those types of severe late effects is by using a fractionated radiation schedule. And that means using small doses of treatment, 1.8 to 2 gray per fraction, daily for 4 to 8 weeks of therapy. And that maximally allows for normal cells to repair their damage. It also allows for two important phenomena that significantly enhance the effect of radiation in cancer cells, and those are re-oxygenation and redistribution. The one drawback of a fractionated 4 to 8 week course of treatment is repopulation. So we already talked about how oxygen can enhance the effect of a radiation, and we can actually quantify that. So this is a cell survival curve, and on the y-axis you have surviving fraction, on the x-axis you have the radiation dose. This is a curve for aerated cells, and this is a curve for hypoxic cells. So in order to decrease the surviving fraction by 90%, in aerated cells it takes a dose of about 6 units of treatment. In hypoxic cells it takes about 24 units of treatment. So that's almost 4 times higher doses required in hypoxic compared to well-aerated cells. So why is that important, and how does fractionation take advantage of that? Well, when you have a collection of cells, you have both hypoxic and well-aerated cells. A dose of radiation arrives, and the hypoxic and the well-aerated cells obviously are killed off, and you're left with mostly hypoxic cells. Over 24 hours, a process called re-oxygenation occurs, where a majority of those cells become oxygenated. Then when the next dose of radiation arrives, they're more sensitive to treatment, and this gradual process of fractionation and re-oxygenation significantly decreases the size of the tumor. The other process that enhances radiation effect with fractionation is redistribution in the cell cycle. This is the simplified version of the cell cycle here with the 4 parts: mitosis, G1, S, and G2. Cells are most sensitive to radiation effect in G2 and M. And when you encounter a group of cells that are in all different phases of the cell cycle, when they receive that first radiation dose, those in G2M are selectively killed. But what happens is, in between, the 24 hours in between, a G2 block occurs, so that the cells start accumulating in the G2 portion of the cell cycle. When that next dose of radiation arrives, you have an enriched population of cells that are much more sensitive to RT. And again, just like with re-oxygenation, you're enhancing the effects of each radiation fraction. The main drawback in fractionation, however, is repopulation. So after about a month, the cancer cells wise up, and they start being able to either alter their pathways or become resistant to treatment, and you start seeing a rapid regrowth at about 30 days. This is more common in head and neck cancer, cervical cancer, and small cell lung cancer, but we can see it in many different tumor types. And that's why it's very important that once you start a radiation course that you finish it in a timely fashion. So basically the take-home points is that ionizing radiation, the target is DNA. The best way to schedule a course of radiation is with a fractionated approach, where you take advantage of the repair of normal cells and the processes of re-oxygenation and redistribution in the cell cycle. The main drawback, of course, is repopulation. So how do we produce radiation for therapeutic uses? Well, this is a linear accelerator here. We accelerate electrons to high energies, and when they hit a tungsten target, they produce X-rays that are collimated, shaped, and directed towards the tumor in the patient. The patient typically lies on a treatment couch, and a machine delivers treatment from 4 to 8 different beam angles. Patients are planned with a CT scan. This is a patient with prostate cancer. You can see the prostate here. The rectum is back here. You can see it on the sagittal slice, and the bladder here. And we designed multiple radiation beams to treat the prostate and limit the radiation dose to both the bladder and the rectum, typically about 7 to 9 different beams. In the past, each beam would be shaped by a lead-lined block, and the beam that left the machine would be of a flat intensity. Modern radiation has replaced these blocks with 120 mini leaves that not only can conform the beam to the tumor shape, but they also can move during treatment. They're dynamic. And this is an example of the intensity of leaf A and leaf B moving during treatment. And that movement produces a modulated intensity beam. And this is an example of that modulated intensity beam. So typically, for this beam, with a 3D approach, the entire beam would be red, signifying a homogeneous intensity. With IMRT, we're able to modulate the intensity of each beam so that the center is red, but there are colder areas in different parts of the beam where we want to spare rectum and bladder. And this is an example of a patient with prostate cancer planned with 3D and IMRT approaches. So this is the prostate here and the rectum here. The goal is for the prostate to receive this dose in red. And you can see with both 3D and IMRT, the prostate is within that red line. The difference is that a majority of the rectum is also in that red line with 3D planning, whereas with IMRT, only a very small portion of the rectum receives that full dose. And that's the real benefit of IMRT, in that the dose conforms more closely to the target. It's more conformal. This all looks well and good, but the prostate, the CT plan is a snapshot of the prostate in time. The prostate tends to move. So between each fraction, there can be a significant amount of movement of the prostate, superior, inferiorly, anteriorly, and posteriorly. So if the prostate were to move a ½ centimeter posteriorly, it's still within that red line with 3D conformal methods. But with IMRT, it will likely extend, if it moves a ½ centimeter posteriorly, it moves into the low dose region. So you've just designed a very sophisticated way to potentially miss the tumor unless you know exactly where it is each day. And that's where the second advance of radiation oncology comes in, and that's called IGRT. And so 90 degrees to the treatment head is a KV imaging source. And that allows us to get a mini CAT scan of the patient before each treatment. It's called a cone beam CT scan. So with that information, on the left we have a CT scan of the radiation plan with the prostate and the rectum in a particular geometry. And this is a scan of the patient while they're on the table before their treatment. And you can see that the prostate and the rectum have replicated that geometry. So we can be very confident that what we plan is what we treat. That allows us to do something else. That allows us to decrease the size of our radiation margins. So in the pre-cone beam CT era, we had to use margins of 1 to 2 centimeters around the prostate, which meant a large portion of rectum and bladder in the field. With cone beam CT scan, we're able to significantly shrink our margin. And as you can see, there's a much smaller amount of rectum and bladder in the field. That significantly decreases, theoretically, the toxicity. Well, what about practice? So this is a table with 3 trials looking at escalated dose in prostate cancer. These are all 3D planned treatments. The patients were randomized to receive either conventional 70 units of radiation or an increase in dose by 5 to 10 units. What the researchers found was that the increase in dose significantly increased disease control by about 20 to 25% at 5 years. But what it also did was it significantly increased the risk of late GI toxicity from 25 to 30% versus 10 to 20% with conventional techniques and doses. The fourth column is a study from Sloan Kettering, where they used both IMRT and IGRT to escalate radiation doses to a level similar to that seen in the other trials. They achieved a similar rate of disease control, but look at the late GI toxicity rate, about a fourth of what is seen with conventional 3D approaches. So that confirms, and there are a number of other studies in other disease sites that demonstrate the enhanced conformality of IMRT, the enhanced accuracy of IGRT results in excellent tumor control with very low rates of toxicity. Well, when we're talking about conformality and accuracy, you really can't beat the Cyberknife radiosurgery system. And so this, I showed you the picture of that large linear accelerator. That linear accelerator is truncated into this treatment head, which provides the radiation source. It's attached to a robot. There are 2 KV imaging cameras on the ceiling and a camera here that is unique. This is able to track the patient's respiratory pattern during therapy. So the robot has 6 axes of rotation, which allows it the capability to deliver radiation from almost 1,200 different beam angles, Compare that to the 4 to 9 different beam angles with conventional treatment, and you'll see the benefit in a second. So this is a patient with a peripheral lung cancer planned with IMRT and Cyberknife. And with IMRT, 7 radiation beams, you can see a good targeting of the tumor, but significant dose spillage into the contralateral lung, the bones, and the soft tissue. With IMRT, an 80 beam, with Cyberknife, an 80 beam plan results in similar excellent coverage of the target, but very little dose spillage into the contralateral lung, the bone, or the soft tissue, which likely will significantly decrease the likelihood of toxicity. So that's conformality, but what about accuracy? Well, the unique feature of the Cyberknife system is it's able to track a tumor during treatment. And it does that 2 ways. First is the KV cameras that are situated on the ceiling. They're able to detect tumors in the stomach, in the thorax or abdomen, where there are radiopaque markers placed in or near the tumor. The patient's respiratory pattern is tracked with this camera, which is called the Synchrony camera. So the patient wears a vest with 3 light beacons that are detected by this camera, and we're able to track the patient's respiratory pattern. We're also able to track the tumor location throughout treatment. So we're able to relate the location of the tumor to the respiratory pattern, and we can actually predict, based on this part of the respiratory cycle, exactly where the tumor will be. So in the past, when we had to use margins of a centimeter or so around the tumor target in the lung or abdomen, now we're able to use margins 1/10 that size because our accuracy is so much improved. So the main take-home concepts are, with IMRT and SBRT, conformality significantly increases the chance that we control the cancer and decreases the chance that we produce significant late side effects of treatment. That promise is realized when we use accurate methods such as IGRT and SBRT, where we're able to track a tumor while we treat it. With better conformality and accuracy, we hope to improve cure rates and decrease toxicity. So let's switch to some clinical scenarios. We've known for some time that in stage 1 and 2 breast cancer, that lumpectomy, removal of the tumor lump, is equivalent to mastectomy in terms of survival, and it allows women to preserve the breast. In the age of good systemic therapy, such as chemotherapy and hormonal therapy, what's the role of additional radiation treatment when in breast conservation therapy? And this is an example of an axial CT scan slice of a woman with breast cancer. This is the lump. We treat the entire breast to a dose of about 50 gray, and then we typically deliver a boost to the lump. With IMRT, we're able to really conform the radiation dose to the tumor target and limit the radiation dose to the lung. And in left-sided tumors, we're able to significantly limit the dose to the heart, again, decreasing the chance of toxicity in either of those organs. This is a table that shows 4 multi-institutional large trials looking at the addition of radiation to breast-conserving surgery in appropriate, well-selected women. And in all the trials, there's a significant improvement in local control in the breast with RT. So the addition of radiation therapy significantly increases the chance that a woman will be able to conserve her breast. But it does other things as well. When you pool all the studies looking at RT in stage 1 and 2 breast cancer, in both node negative and node positive, there's a significant improvement in local control from 40 to 50% in both N0 and node positive. But you also see a small but significant improvement in breast cancer specific survival with the addition of RT in both node negative and in node positive. And in node positive, it's almost 9%. And that's a concept in trimodality therapy. When you have optimal local treatment and you have optimal systemic treatment, good local therapy can actually improve survival. And we see that in brain tumors, GBM, we see that in esophageal cancer, we see that in gastric cancer, and hopefully someday we'll see if we have an improvement in systemic therapy with sarcomas, we'll see that in that disease as well. The other concept is that limited surgery with the addition of radiation therapy really optimizes the chance that you preserve the organ. And we certainly see that in sarcomas, where radiation significantly decreases the chance of recurrence in a limb extremity, for example, and increases the chance that the conservative surgery is successful. The other concept that I wanted to emphasize was combined modality treatment, and we see that, and I use head and neck cancer as an example of that. So for advanced larynx cancer, the traditional treatment was laryngectomy, where the patient would lose their voice box and be left with a stoma. This is an example of a normal larynx, and this is a larynx tumor. Patients typically present with hoarseness, sore throat, and difficulty swallowing. In the 1980s, a VA trial suggested that if you deliver sequential chemotherapy followed by RT and reserve surgery for salvage, that you get excellent control rates. About nearly 2/3 of patients are able to preserve their larynx. And this is an example of an IMRT treatment course for a patient with larynx tumor. Tumor is treated here in the red. The lymph nodes are treated by the green. You can see how the radiation dose can kind of bend around the spinal cord. And that's more important higher up when you're treating the lymph nodes higher up. You can see that the lymph nodes are well treated. We're able to bend the radiation dose around the parotid glands to potentially spare this patient of dry mouth for their treatment. In the 1980s, there was a trial that compared sequential treatment, as was done in the VA system, to combined modality treatment, or RT alone, in patients with locally advanced larynx cancer. And what they found was that, as we do in a number of disease sites with combined modality treatment, that acute toxicity is significantly higher with combined modality treatment, both mucosal toxicity and swallowing toxicity. In parentheses, I have the toxicities with IMRT, which are significantly lower. But the acute toxicity are higher, but the late toxicity rates are not higher. And in fact, the likelihood of preserving the larynx is significantly higher in those patients who received the combined treatment as opposed to sequential or RT alone. And this is something that we see in a number of disease sites as well, including many GI cancers, GYN cancers, and GU cancers. The final scenario is stage 1 lung cancer. So traditionally, stage 1 lung cancer is treated with surgery, either pneumonectomy, lobectomy, or sublobar resection. For patients who are not candidates for surgery or who decline surgery, the question is what options are there? In the past, traditional radiation was an option. The control rates, however, were poor. And so now, with modern radiation, improved accuracy, improved conformality, we can offer SBRT, which ideally treats a peripheral lung lesion measuring less than 5 centimeters in size. And we do it in a very radically different way. So with conventional treatment, we talked about 1.8 to 2 gray per fraction, 30 treatments over 6 weeks. With SBRT, we're able to do 10 times that daily dose. We do it in 3 treatments over a week and a half. And the dose that the tumor sees because of that significantly truncated schedule is significantly higher than with conventional treatment. And the studies support the use of SBRT. So these are five single institution trials with well-selected tumors, delivering doses of 12 to 20 gray in 3 fractions. And you can see excellent local regional control rates of 80 to 95% with very low rates of toxicity. And that's because of the excellent conformality and accuracy of treatment. And this is an example of a patient that we treated. You see the peripheral lung tumor away from the central structures of the appropriate size, received 60 gray. And by the time you get to the blue line, only about 1/3 of the dose is there. So you see a sparing of the normal structures, very little dose in the contralateral lung. This is the PET scan pre-treatment. You can see an active lesion here. And post-treatment, you see not only is the lesion not active at 1 year, but it also has not increased in size. And control rates for the target lesion that we've seen are between 90 to 95%. So I just want to conclude and just sort of sum up. Modern radiation, the goal is to produce a more conformal treatment that is delivered in a more accurate fashion. We do that with IMRT, IGRT. We optimize that with SBRT, which allows us to radically change our radiation schedule from fractionated to hypo-fractionated treatment. The goal, obviously, is to try to improve cure rates and decrease toxicity, and we do that with trimodality therapy, combined modality treatment, and in certain well-selected cases, single modality treatment. So with that, I'll end. Thank you for your time.